Just with a blink of eye, COVID pandemic 19 has thrown us into such a turmoil that many of our nearest dearest person, many healthcare providers and many people have sacrificed their lives across the world. We cannot miss each other, but life has to move on, and that is why BIMSSCON has organized such a wonderful and important webinar to 2020. I would like to congratulate all of you for this very good and time-demanding initiative. And me, Professor Zinnat Ara Nasreen, working as a professor and head of the Gynae Obs Department, Sikdar Women's Medical College and Hospital, and also I am working as an organizing secretary of OGSB. I am really very much proud and honored to be the part of your webinar today. My heartiest thanks and gratitude to you, all the BIMSSCON. I hope that this webinar will really help you, all my beloved students. Though today I have chosen 3 important topics, that is normal delivery, pre-eclampsia, and polycystic ovarian disease. Well, with this short time, maybe I can't speak all of that, but I tried my best to speak out the gist of them, but I have written the slide you may go through later on. Hopefully, you'll enjoy the whole webinar, and for all of you, I have prayers and best wishes and love from my bottom of heart. Thank you so much. Normal vaginal delivery. I mean, this is a very important topic for the obstetrics and all the students, even the doctors, they must know that. So, you see, all through the normal vaginal delivery, we need to have a respectful maternal care. A mother at the end of the normal vaginal delivery can remember, can cherish the journey with you. So what is the normal vaginal delivery? Well, you see, here the baby is in the uterus. The baby has to come out to the exterior world with a lots of series of events. But when it is normal, if the baby is a single with the vertex presentation, and the labor starts with the normal, spontaneously, and the labor ends without any undue prolongation or undue complication for the mother and the baby. That is the normal vaginal delivery. Well, normal vaginal delivery usually starts with the true labor pain. The true labor pain is a regular, intermittent, and it comes usually after a gap. So, a doctor or a student must know what is the characteristics of labor pain. Labor pain usually starts at the back and it radiates towards the middle of the thigh, towards the inner thigh, and it is intermittent. When it comes, it goes immediately. And slowly and gradually it increases in duration, intensity, and frequency. That is a true labor pain. So you have to identify the true labor pain from the false labor pain. So labor starts with the true labor pain, and you'll have to know what happens with the abdomen. So if a lady comes to you with the pain, and if you examine her and touch her abdomen, you will see there will be hardening of the uterus. That will tell you it is a true labor pain. At the same time, if you go for the examination to the cervix, just have a look. This is the cervix, this is closed. So it is not labor pain. Even she is having a pain and hardening of the uterus. So if you do the PV exam, if you find that it is opening, the cervix is open, dilated, effaced, and there's a red show, that is actually true labor pain. So, the sign of true labor pain, hardening of the uterus, and the dilatation and effacement of the cervix. And definitely when true labor pain starts, there will be progression of the presenting part. I just want to mention an important point before starting how to establish your diagnosis. Just have a look. This is the cervix and this is the vaginal wall. And this is the baby's head, bag of membrane, and the cervix. The cervix at the beginning remains too long, but the baby has to come out. So the cervix need to be dilated, need to be opened up, and it to be short, and that is called effacement and dilatation. So when a patient comes to you, first of all, you'll take the detailed history. That is whether there's a characteristic labor pain, whether she has seen some shows or blood mixed mucus discharge, whether she has seen any water breaks. You have to ask all these questions. And definitely by the taking history with her advanced gestation, expected date of delivery, you can understand, well, it could be a labor pain. Then you have to go for the examination. Whenever doing examination, you have to do the general examination as well as the obstetrical examination. General examination as usual for each and everyone, like pulse, blood pressure, temperature, what is her pain, how she is, everything, the state of dehydration, anemia, edema. So everything you have to check. And obstetric examinations example, you have to touch the abdomen, you have to look at the baby's longitudinal, what is the presentation, vertex, that is a normal vaginal delivery, so vertex, and what is the position of the baby, what is the heart rate of the baby. And if everything is normal, then you have to do the parvaginal examination. I already mentioned that cervix, for the true labor pain, the cervix is opened up like this. So, and you might get the show, and sometimes membrane ruptured, sometimes there may be membrane intact. Well, the true labor pain you diagnosed, yes, it is labor pain because she's having characteristics labor pain, she's having show, she's having progression, a dilatation of the cervix, and the baby is fine. So you're happy that your diagnosis is okay. But in which stage she is? Is she latent phase or active phase? Latent phase is a variable time period when the labor starts, but not as like active labor. So when you say active labor or active phase, when the cervix, I just mentioned before, the cervix when dilated from this to up to 4 centimeter, because when the cervix is dilated 4 centimeter, the pain increases and the uterus hardens. So the labor pain is active labor. And we have divided the labor as the first stage, second stage, and the third stage. First is start from the 4 centimeter dilatation of the cervix and last up to the full dilatation of the cervix. And just I have mentioned, and contraction is usually very, very frequent. Every 5 minutes, lasting from 40 to 60 seconds. Remember, initially she might not have too much pain, and the pain may comes at a longer interval. But now, at the later part of the first stage, when the cervix is fully dilating, then the pain may come every 5 minutes, every 3 minutes, and it may last longer, 40 to 60 seconds. So, what is your duty? Loving and tender care. Let her walk initially. Later on, she'll go to the bed. Then ask her to drink. Have some analgesics. Labor pain is very, very much pain, so you have to give analgesics. Antibiotics according to its guideline. Well, in our country, we provide antibiotics. And you have to have very vigilant for the maternal condition, fetal condition, and the progress of labor. Unfortunately, these three can be combined in a graphic paper that is called the partograph. So partograph is essential part of your labor monitoring. Yes, you have to give instruction to the patient. I told this respectful maternal care, not only your duty just to see the maternal condition, fetal condition, and plotting the chart in partograph. You have to ask the patient to be calm, quiet and get all the support from her near or dear person. So we came in the first stage. What is that? That it a true contraction from 4 centimeter to the full dilatation. It is almost in the full dilatation. You see, the cervix is opened up and the head is like this way. And by that time, there are a lot of events are going on in the uterus. So what will happen? The baby will flex, baby will descend, and then baby will rotate completely so that the occiput comes just beneath the pubic symphysis. And when the biparietal diameter will cross the outlet, you'll see the beautiful hair of the baby. So it is up to the first full dilatation, and now baby will be delivered. But you see, you are in the accoucher, you have already got ready, you're wearing masks, gowns, a cap, getting ready the baby's trolley and talking to the mother, and somebody is helping you, some midwife is there, or some doctors will be with you. So when you see the mother is pushing, you can see the head is popping up. But again, when mother doesn't have the contraction, it will go back. But a time will come when the head will not go back, no recession. So that is called the crowning. And crowning means the next contraction, the baby head will deliver. So this is the time when the perineum is stretched, and you can decide whether she needs episiotomy or not. Usually, in our time, we used to give episiotomy to all, especially the primary gravid. But in your time, it's not a mandatory. If you think it is stretching too much, there will be tear, then only you can give the episiotomy. Or if you do some, instrumental delivery. But here we are going to do the normal vaginal delivery. So if it needs, we will give the episiotomy. It could be the medial, mediolateral. Mediolateral is better. So we are waiting for the baby's head to be delivered. Now let's see what to do. Yes, second stage is very important. First stage up to the full dilatation. Now baby will be delivered, and that is the second stage. Second stage is the time when the baby is delivered. So this is the most important time. You have to be cautious so that the mother can push properly. Proper instruction to mother is important. I have written here, but if I read line by line, I can't finish. So it is there. Whenever you get time, you'll read that. So one important thing, ask mother not to push when there's no pain. But if she feels pain, if uterus is hard, then only she should push. That will be effective. So this is your duty to train mom that you have to push right now. That is the way, with the mother's cooperation, your nice communication can bring out the baby safely. You see, now the baby, I told you, the second stage is the delivery of the baby. The pubic symphysis is here and the baby's occiput is just here. Unless and until baby is completely rotated, you cannot deliver the baby. So baby was in flex condition, I showed initially. Now the baby's head is born by extension, looking at you to say hello. Yes, so this is all. I have written this one. I am not reading all the things, but you read your own. Just you will see what to say, you should instruct the patient. When the baby's head come out, you can say, thank you mom, your baby has been delivered. Now you're bringing the whole baby to show you. Congratulations. So this is very important. And the birthing position actually, it's, what the mother feels comfortable. If she wants to deliver in squatting position, if sitting position, in birthing chair, in, whatever hard position she likes, we have to allow that. But it is seen that squatting position enhances the delivery faster. But always it is the choice of the mother. You can tell her all the positions, birthing position, whatever she likes, whatever she feels comfortable, allow that one for her. Now, you see the baby's, I showed in the last picture. This is the baby's delivering. The baby's head is being delivered by the extension. So the baby's head came out with the extension. And so we have, immediately you have to wipe the eyes, nose and mouth. Then you have to hold the baby's hand nicely with the two hands and just, you see, If the head is delivered, baby has completed its rotation. Now you have to pull a bit down so the anterior shoulder will come. See? Yes, it is anterior shoulder delivered by gentle pulling down. Then you have to pull a bit up so that the posterior shoulder will come, and the rest of the body will be delivered by lateral flexion. And then the important, once baby is delivered, we think, oh, our job is done. But no, you have to do a lot of things. Second stage is just gone. Third stage is coming. Third stage is delivery of the placenta, membrane and cord. So once the baby is delivered, you have to clamp the cord with a clean knife, or the, scissor. But if it is in the periphery, you need to use the blade, clean, sterile blade with the clamping on either side. Usually you do the cord clamp a delayed 1 to 3 minutes time. And give the mom to the mother, to the chest, skin to skin contact. Give the mother after drying, then with an extra towel, give the mother's open skin and baby's open skin, and give a warm towel or blanket over them. So mom will be happy and baby will try to suck. That is very important. Your duty is not yet finished. You have to deliver placenta. So this is the third stage, delivery of the placenta. Well, placenta can be delivered even if you don't touch. That is called the expectant management. But we do active management. You are students. You are taught to deliver placenta by active management of third stage. What is that? Active management third stage is to administer Syntocinon 10 units IM in the thigh of the mother, and then deliver the placenta by control cord traction. Control cord traction means you have to push the uterus upward and gentle traction on the cord, so it will be delivered without inversion of the uterus. So control cord traction. Why you do this control cord traction? Why don't you do the expectant treatment? Because it has been research said, if you do the control cord traction, PPH can be reduced by 40%. So third is over, placenta, cord and membranes is delivered, but you need to check whether the placenta is intact. This is the fetal part. You see, it is totally intact. It is the maternal side, whole side you have to intact. Well, just one thing I want to mention, we are giving Syntocinon, but sometimes in the far remote area where the IM injection is not possible, Syntocinon is not available, they can give the 600 mg misoprostol, which will act to prevent the PPH. Instruction to the mother, same, you have to be very kind to the mother. Always respectful maternal care, that yes, we have delivered your baby, we are giving the baby, right up the baby, giving on your chest, please try to, suck your baby, and that is a wonderful thing. And that also helps, to reduce the PPH. So fourth stage, actually it is not that serious stage, but it is for our extra precaution, we take the fourth stage because this is the time, 1 to 2 hours time, when maximum mishap occurs, like PPH or shock, obstetric shock, anything may happen. So we take special care during this period. What is most important, we do the routine uterine massage, usually 15 minutes interval for 2 hours, and ask how is the mother, how is the baby, whether the breastfeeding started, how they're feeling, everything we take good care, and definitely again maternal respect care to them and thank them. That is all our liver normal vaginal delivery. Well, I didn't talk line by line, so please read all the lines I wrote because you can read later. Just at a glance, what is happening mechanism, because this comes in the OSPI, this comes in the OSPI station, in the SAQ, in the MCQ, in the written. Just at a glance. What happened? Stages of the liver. You see, the baby's head was floating before engagement. But once the labor will start, before some time or during the time of battle, engagement occurs. Engagement, you see, that bipyramidal diameter crosses the pelvic brim. That is the engagement. Then flexion occurs. Then further descent occurs. And, due to good uterine contraction, further descent occurs. with internal rotation so that the occiput comes under just beneath the pubic symphysis, and the deliveries. The cervix fully dilated, and this is the head, and then the baby is delivered by complete extension. And then there is restitution and lateral rotation, so the its anterior shoulder comes beneath the pubic symphysis, and the pubic symphysis, when the anterior shoulder comes, it is delivered, and then posterior shoulder delivered. So that is actually picture the mechanism by which what's happening inside the uterus, So that is also very important. So with this, I like to stop here, and thanks for the attention. You see, this young lady, she will be pregnant tomorrow or day after tomorrow, and she will come to you. You are the student today, tomorrow and day after tomorrow you are the doctors. So we hope you will get the respectful maternal care for all women. Thank you very much. Polycystic ovarian syndrome, a very common disease all over the world. So you have to know. What is this? Actually, it is a heterogeneous, commonest endocrine disorder in women, which occurs about 10% of women of young reproductive age, though it could be higher in obese and in infertile women. So, the incidence 5 to 10% in general population and 30% in fertile population. Well, what should we read today, or what should we learn today? My learning objectives are definitions, diagnostic criteria, small, short pathogenesis, complication, and how to manage. You see, the most accepted definition of the polycystic ovarian disease is now the association of hyperandrogenism with chronic anovulation in women without a specific underlying disease of either for the pituitary gland or for the adrenal gland. Not mandatory or not necessarily they have to have polycystic ovaries in the ultrasonogram. So diagnosis according to the Rotterdam criteria, 2 among the 3. What are the 3? The first of all, oligoanovulation, hyperandrogenism, either clinically or biochemically, and the polycystic ovary in the ultrasonogram. Either these 2 or these 2 or these 2. But most currently we are telling that if anovulation and hyperandrogenism, the combination is the diagnostic criteria for polycystic ovarian disease or syndrome. Just simply I would like to inform you so that you can remember, normally the ovary is like that, but in polycystic ovary there are a lot of cysts are arranged in the periphery like necklace pattern. Why? What is the pathogenesis? I will tell you just before you know. Ovaries are there for steroid synthesis and the ovum production or oocyte production. You see, that is a thicker cell. This is the thicker cell, it is the granular cell. They are in the stroma of the ovary, and the thicker cell produces cholesterol, from the cholesterol to progesterone and testosterone, and this androstenedione goes into the granular cell to produce estradiol. So what happens during in a normal woman, what happened during ovulation, I mean just before ovulation, lots of primordial follicles, they try to compete each other to get the dominancy, and only single follicle become a dominant follicle. And that is the normal part of life. But you see, in the polycystic ovary, there's no dominant follicle, no ovulation, only the small follicles are arranged along the periphery. And that was first described by Steen Leventhal. They said hirsutism, obesity, and ovulation. And obesity first or hirsutism, it was not very clear at that day. Still now, we don't know, like a dilemma, which is first, the chick or the egg. Pathophysiology, just in short, I can say, yes, the pathogenesis is still, it is elusive. We don't know exactly what is happening. But, you see, it is a very nice picture. Just this one picture will tell you the whole scenario of the pathogenesis. Maybe the genetic, maybe the environment, food habits, sedentary work, or the gene altogether causes insulin resistance in the body. Insulin cannot work through the receptor. So the cell at cellular level there is no sugar. So pancreas secretes more and more insulin so that it can help the sugar to go inside the cell. But there is a resistance. No cells are getting sugar appropriately. So there is a hyperglycemia. Sugar is only in the blood. That causes liver to produce less sex hormone binding globulin. As there is less sex hormone binding globulin, so more androgen in the periphery. And again, there's hyperglycemia, so release of fatty acid. They produce cytokines and fatty acids, and that also leads, it's increased inflammatory cytokines. And this all together works upon the ovary to produce more and more androgen. So ovarian androgen is very high in the circulation. And in turn, there is more estrogen, less FSH, and LH is more. So there's insulin resistance. 1 in 3, this is a very alarming, So polycystic ovarian disease, we have to know the gravity of the disease. The most important is insulin resistance. That happens in 1 in 3 women. Well, how the patient presents to you? I already mentioned in the diagnostics that patient may come with the oligoaneuplosion or aneuplosion. That means they will have, menstrual irregularities. They might have some 4 or 5 months amenorrhea. Many of you are also suffering from that, So, and then sometimes they don't have period for even 1 year like that. And many of the later part, they suffer from infertility. And other aspect of the polycystic ovarian disease, that women or the girls or the adolescents, they're coming with the hyperandrogenism. I just mentioned in the pathogenesis, there's a high androgen in the blood. And they come with the acne, pimples, hirsutism, acanthosis nigricans, and obesity. And that really, embarrasses them too much. And 33% of these PCOS women might have the metabolic syndrome. And that is is a very dreadful thing. And if you look at the women or the girls, younger girls, usually all the women have, pear-shaped abdomen. But they will have, apple-shaped, because more and more visceral, adiposity, visceral adiposity, fat is deposited in the abdomen. The abdomen becomes very huge because of this hyperinsulinism or insulin resistance and metabolic syndrome. The girls are very sad, very upset because of hirsutism. It's too much in the face, cheeks, everywhere. The pimples, and they become, acne vulgaris. Not only that, they have got the acanthosis nigricans and blackening of the whole skin. Their beautiful color goes off. They become fat and obese. And this is just like, the PCOS, as if it is a thief of womanhood. Sometimes they feel, is it their sin? But actually not. This is a metabolic syndrome. Insulin resistance, I already mentioned in the pathogenesis, and that is the PCOS results in insulin resistance, which gives later on liver disease, that is NASH, cardiovascular disease, diabetes, other obesity, other comorbidities, and even uterine cancer. Yes, psychological impacts too much. Even 30% women suffer from tremendous psychological upset. They may suffer from depression, and it is heard in the literature, many of girls, because of this PCOS, they wanted to commit suicide. So that could be the presentation. What you do the examination? Definitely any examination, whenever you are asked to do the examination, you do the general examination and the specific examination. For PCOS, you have to look at the BMI, abdominal girth, for abdominal examination. And if they're married women, you have to go for the vaginal examination to exclude other pathology. Yes, that is very important. You can't say PCOS unless there are, the differential diagnosis. All the disease should be absent before you go to say it is a PCOS. What are those differential diagnoses? Congenital adrenal hyperplasia, it could be Cushing's syndrome, could be hyperprolactinemia, could be hypothyroidism, intake anabolic drugs. I mean, sometimes people are taking danazol, that is anabolic drugs. Too much danazol causes hirsutism too, and hormone-producing tumor. So that you have to keep in your mind, and only then you can diagnose the PCOS. So we have to take the history. I have shown you all the symptoms, your clinical examination, and you have to know the differential diagnosis. Investigation. Well, investigation, you can do a lot of investigation, but the history will guide you which particular type of investigation you need to do. But definitely we'll go for the ultrasound scan and the endocrine profile. Especially you can see that FSH, LH, the reverse ratio. I showed in the pathogenesis, LH ratio is very high. LH goes up. That is the reason there's a hyperinsulinemia too. Estradiol remains normal, FSH normal, prolactin is increased, and that is the ovarian prolactin, not from the pituitary gland. And free testosterone is increased because sex hormone binding globulin is very low, and inhibin increase, fasting insulin raises, and if you go for the abnormal glucose tolerance test, you will find that the GTT, yes, there might be abnormality, especially who are obese, whose BMI is high. And ultrasonogram whole abdomen to look at the adrenal gland as well as the ovaries. Treatment. Treatment mainly focus to the specific symptoms the girl is having or the woman is having. I mean, is she suffering from onigo or oligo anevolution, irregular bleeding, or infertility? Then you treat accordingly. Or if she is suffering from hyperandrogenism, like hirsutism, acne, obesity, acanthosis, you have to treat that. And look at the general health. Is she suffering? Because in the long-term PCOS may produce hypertension, diabetes, cardiovascular disease, sleep apnea, NASH, so many morbidities. Is she having any general health risks? If so, you have to treat that. So treatment needs to be tailored according to the symptoms. General treatment is very important. Weight reduction. I mean, many of the women are obese. They are obese. Their BMI is high. So your first duty to request them to reduce the weight. So weight reduction, even if you ask them or if they can reduce 5 to 10% of their own weight, all the metabolic syndrome may reverse back to normal. I mean, PCOS symptoms and signs will be ameliorated. So that is a very important that you have to ask her to reduce the weight, and they should maintain the normal BMI. Yes, exercise is very important, but it's not very easy to do the exercise. We always tell the girls or the women, do exercise, but this is very difficult to make them to do that. So ask them whatever they like. It could be, sorry. It could be walking, it could be jogging, it could be running, it could be dancing at home, it could be skipping, swimming, cycling, whatever they like. And the drugs. So after the lifestyle modification by diet and exercise, they need to take some medicine. Hormonal contraceptive is the choice of treatment. That is a very important drug for the adolescent as well as for the young women who do not want pregnancy. So the OCP, it will regularize her normal period. It will help her to reduce the hyperandrogenism. But if with the OCP lifestyle modification she is not responding, then you can give her some anti-diabetic or insulin sensitizing agent like metformin. Metformin works tremendously. And for hirsutism, you can go for spironolactone, finasteride, and flutamide. So the lifestyle modification, diet, exercise, and the drugs. I have written all the drugs here, including the metformin. You can go and read that. So I'll finish by saying, infertility, we can send her to the infertility center. They will do infertility test. And lastly, I would like to mention that PCOS is a common disorder in young adult. It begins from the in utero, childhood obesity with the menstrual problem, pregnancy, complication, and metabolic syndrome. Lifestyle modification is the first line of intervention. Yes, OCP metformin is an added benefits. The psychological stress is very important, so you need to treat her holistically with loving, tender care. Thank you. Pre-eclampsia is one of the important causes of maternal death in our country and also our neighboring country. So you all must know what is pre-eclampsia, how to manage that. And so today my objective is definition. I will teach you definition, classification, prediction, prevention, and the management. Well, this definition actually changed. What we have learned, what we have told you, that blood pressure, it is a multisystemic disorder when the blood pressure is more than 140/90 with proteinuria, which appears after 20 weeks in a pregnancy of a woman who was previously normotensive and non-proteinuric. But this definition is changed. New definition is, of course, preeclampsia is a multisystemic progressive disorder characterized by the new onset of hypertension, that is 140/90 and above, and proteinuria, or may not be proteinuria. So, or new onset of hypertension above 140/90 and significant end organ dysfunction with or without proteinuria in the last half of the pregnancy. So, the change is only proteinuria. So now if you are asked to define preeclampsia, it could be new onset of hypertension, whatever you will say, the new onset of hypertension with proteinuria, or new onset hypertension with the evidence of end organ dysfunction, which appears after 20 weeks in a pregnant woman who was previously non-proteinuric, non-hypertensive. Okay, the change here only is the proteinuria, not mandatory. Hey, yes, if the hypertension proteinuria, that is the preeclampsia, or proteinuria is not there, no problem. If hypertension and end organ dysfunction is to be called preeclampsia. So diagnosis, well, the systolic blood pressure should be above 140 or 140, and diastolic pressure should be above 90 or more. So the important thing that if somebody, if you measured and the blood pressure is 140/90, immediately you can't say she's hypertensive. You have to take at least 2 consecutive subsequent and 140/90 blood pressure and up, at least 4 hours, then you will take it as a hypertensive. But if the blood pressure, probably you all know that preeclampsia is divided into two type of preeclampsia. One is the mild and another is the severe. Mild is 140/90 above, and severe is 160/110 above. So in between is no mild, and when it is 160 and above the blood pressure, severe. So in case when you are finding that somebody is having 140/90 and above but below 160/110, then it is okay to take the blood pressure 4 hours apart. But if it is high, 160 and 110, then 4 hours will be too long, isn't it? So at that time, we have to take twice, but maybe 10 to 20 minutes after. Okay? So the new nomenclature, it is simply, it is not very difficult, that preeclampsia when the blood pressure will be high with proteinuria or any of the following sign. What is that? It could be, yes, it could be proteinuria. It could be any organ dysfunction. That is hypertension with acute injury, hypertension with the liver involvement, hypertension with the neurological complication, hypertension with hematological complication, or hypertension with uteroplacental dysfunction, that is indicating fetal growth restriction, abnormal umbilical Doppler, or stillbirth. You see, proteinuria is not mandatory. Why? Because without proteinuria, preeclampsia can damage many of organs. So you have to think about that. So preeclampsia, yes, hypertension, of course, with proteinuria, or any of this one. What is the pathogenesis? Pathogenesis is very simple. In normal pregnancy, what happens, you all know that invasion of the cytotropoblastic cells, it invades the theca, intima and media of the spiral cells to make them white, large caliber, large capacitance vessels. So that the blood supply will be more and more to the fetus from the spiral arterioles. And that is the normal change of the pregnancy. But unfortunately, in preeclampsia, this changes doesn't occur. Rather, the spiral vessels remains narrow, constricted. So blood supply to the placenta is very less. There's ischemia of the placenta, which results in production of a lot of cytokines, lot of soluble cytokines and chemical mediators. Those actually affect the endothelial cells of the blood vessels all over the body, and that gives the dysfunction of the endothelium, and that results different type of manifestation and the organ damage, end organ damage. Can you predict preeclampsia? Is it possible? Because if we can predict the preeclampsia, we can take special care for those ladies so that she doesn't develop eclampsia, and we can reduce the maternal mortality. Scientists are trying since long. Well, we got some risk factors. That is also important. No, by that those risk factors we can understand. Yes, these ladies can develop preeclampsia during the course of antenatal period. So who are those ladies? Well, if somebody is having preeclampsia before hypertension pregnancy, who are having chronic kidney disease, who have chronic hypertension, who are having diabetes, who are having autoimmune disorder like SLE, antiphospholipid syndrome. And if the women are coming to you with the first pregnancy, she is the more riskier than the subsequent pregnancy. Age is 40. I mean, India has given some score, but we can remember this one is nice guideline. If age is more, pregnancy interval is more than 10 years, BMI is more, there's a family history of mom or sisters, and multiple pregnancy. So these are the risk factors. Can you do some tests? Yes, there are some tests like, Doppler ultrasound finding. Actually, you will be asked so many things, but you might be asked that what are the maternal specific characters which may predict that she is a high risk. So that is the most important. But you can just know that yes, there might be ultrasound finding Doppler, it may predict. Or there are some biochemical markers which can be estimated. You don't need to memorize all these things. Just we can predict by the history, maternal characteristics, and Doppler ultrasound of the uterine artery, and some biochemical markers. Prevention? Yes, if you can diagnose earlier, appropriate management, time delivery can prevent the progression of the disease. You cannot change the preeclampsia, but you can prevent the progression of the severity of the disease, and thereby you can prevent the eclampsia, you can prevent the multi-organ failure. So but how you prevent? Definitely who are coming for the pre-pregnancy, definitely you ask them to lose their weight if they're overweight, not to smoke, maintain the regular exercise, and once they're pregnant, during antenatal period, you can prescribe them 75 milligram aspirin. It has been seen that it has a preventive role. And also you can give elemental calcium. World Health Organization recommended that. And of course, during the whole antenatal period, you need to be very careful about checking the blood pressure. That is the most important thing. Because if you can get the proper blood pressure in appropriate manner, you can take the blood pressure, you can diagnose this is the high pressure, you can give the appropriate treatment. Classification, actually this is, this classification is hypertensive disorder pregnancy. If the women, the hypertension, if you find before 20 weeks, it could be chronic hypertension. This is not a gestational hypertension. And it could be essential or secondary and white coat hypertension. White coat means when they're coming to the doctor with their pressure increases. But when they go back to home, their pressure normal. But that also need to be a follow-up because they might develop in some point hypertension. But after 20 weeks of pregnancy, if blood pressure comes, we tell that gestational hypertension, transitional where no proteinuria, gestational hypertension. Yes, I already mentioned, maybe it is associated with proteinuria preeclampsia, or if not proteinuria, they might have some organ dysfunction, that is also preeclampsia. Okay, now if you know that she is hypertensive, and you think she's preeclampsia from history, then management can be done as inpatient, as outpatient. Mild preeclampsia can be managed as outpatient patient, and severe preeclampsia or preeclampsia with severe organ disease can be treated in the hospital. The most important thing, the close maternal monitoring soon after diagnosis of the preeclampsia. Hospitalization is the key. And then I'm telling you for the outpatient. The women who you got hypertension and you diagnosed her as a preeclamptic patient. So if she has a mild hypertension, probably after some observation, you can let her go. If you think she needs hypertensive drugs, you can give her. But it is very important that she should have home monitoring. And you have to teach her. Otherwise, it is very difficult. Or she can have checked her blood pressure by some nearby pharmacy. So that is very important. And advice, yes, restricted movement, not the bed rest, as she is a mild preeclampsia. And whenever she lie, it is better to lie on the left lateral side. And the drugs we can give her, antihypertensive, I'll discuss that. Calcium iron, as usual, normal pregnancy, what are you giving? And the telemedicine is important because she is hypertensive. You are discharging her home. She's not in the hospital, so you have to give her a number so that she can immediately talk to you or your assistant, so that time to time she can get all advice. And you have to inform her vehicle, and not only the patient, her husband or her parents or guardian, they need to be educated, because preeclampsia at any time can be transformed or shift into severe preeclampsia. Now, severe preeclampsia, to who we shall call severe preeclampsia? The first of all, this is nowadays it is called preeclampsia with severe disease. No more severe preeclampsia, but you can read also severe preeclampsia because it is in your book. When I already mentioned before, when the blood pressure is more than systolic 160 or diastolic more than 110. Two occasions. Here it is written 4 hours, but I already mentioned, no, we shall not wait that much. We shall recheck after 20 minutes, because we don't want to wait longer. There might be complications. Or patient may complain of central nervous system like photophobia, scomata, blindness, headache, because of retinal vasospasm. They might complain severe headache. Hepatic abnormality they might complain, and you might see. And actually, hepatic abnormality, they might complain you that, yes, I am getting severe epigastric pain, hypochondriac pain, I am nauseated, I am vomiting, or I have vomited. And if you examine, you might get the tenderness on the right hypochondriac area. So these are the symptoms and signs together. If you go for some biochemical testing, there might be impaired liver function test, there might be coagulation profile abnormality, kidney function abnormality, and evidence of pulmonary tumors would be present. If these are present, you should to read, I have written everything, then it will be called severe preeclampsia or preeclampsia with severe disease. Principle of management is very important for preeclampsia with severe disease, because that might go into eclampsia at any time. So mainly the principle to prevent the convulsion or other complications like pulmonary edema. Control of hypertension, definitely. We have to balance the fluid. We should not overload her. We need to assess the fetus, assess the mother, and we have to find out, is there any evidence of the fetal compromise. So obstetric management, now as she is a preeclampsia, we know that delivery is the only treatment. So we have to determine the timing of the delivery, route of the delivery, and the place of delivery. And if we can't manage in our own hospital, in that case, referral should be there. So for mild preeclampsia, I told how you can manage in the home. She will come to you time to time. You'll check her, and you'll take her up to the expected delivery with close monitoring of the mother and the baby. And severe preeclampsia, you can't send her back home, because that is a very emergency. You have to admit her. Admission, it is depend upon your hospital setup. It could be in high dependency unit, it could be delivery unit, and patient need to be monitored at least 48 hours, whether she's deteriorating or she's improving. How? You have to give the bed rest, you have to give antihypertensive, a steroid if she's preterm, and the Sikdar prophylaxis. I mean, we have to give a magnesium sulfate to prevent the eclampsia. Of course, monitoring is very important. Recording of the fluid intake output chart is also very important. Her blood pressure, if stable, we can wait. And if her biochemical results are stable, we can wait. Her baby is fine, we can wait. Investigation, I am not telling you, you will just look my slide. Here everything is written. You have to go all this investigation, very important. Maybe some question will come, what are the investigation you do a pre-eclampsia with severe organ disease or severe pre-eclampsia? Treatment, well, treatment has to be done. Before, no, there's too much debate. Hypertension 140/90, 150/100. Do you need to do the treatment? Do you need to do antihypertensive? Now the consensus is yes, because treating hypertension can reduce neonatal death and it reduces the progression to the severe disease by 50%. What are the antihypertensive drugs? You will be asked. Labetalol, methaldopa, nifedipine for a stable case for mild preeclampsia. But for severe preeclampsia, you can't give oral one. Might be she's not in that state to take. If she can, we can give that. And acute hypertension is very high. We have to give labetalol infusion, hydralazine, and nifedipine. Because antihypertensive can reduce, 50 to 70% to progression of the severe disease. Okay, actually here I have written some doses for you. If you want to read, you do just simple 1 or 2 drugs, you can read the doses, not details, but I have written you for yourself because it might help you. For prophylaxis of seizure, I mean to prevent the eclampsia, prophylactic dose of loading dose is needed for the prevention of eclampsia. That is very important. Whatever the gestation is, we have to give the magnesium sulfate. I have written all the dose here, and what are the precaution you will take, I have written. Please go through. Fluid balance, I already mentioned, is very important because the pathogenesis, that endothelium of the blood vessels are sick. There is a dysfunction. So the intercellular compartment is dehydrated. If you give fluid too much, that will go into the extracellular fluid and producing pulmonary edema and death. Steroid, definitely. If it is preterm, before 34 weeks, we have to administer the steroid. And steroid administration not only matches the lung, helps in the lung maturation, it helps prevents the ventricular leukomalacia, interventricular hemorrhage, the necrotizing colitis. It has a lot of benefits. So we have to give steroid, but we have to cautious about the repeated dose. I have written here. You might go through where the doses is given and the repeat dose I have mentioned. Now the most important thing, that when to deliver, because pre-eclampsia we cannot prevent. I told already, but if we can predict, we can prevent the progression of the disease, and the delivery is the only option of treatment to end up the preeclampsia. So timing of delivery is important. When to deliver? Well, if my patient is 37, if my patient is having a mild preeclampsia, the baby is okay, it's not jeopardized, maternal condition is stable, and the biochemical markers are fine, then we can deliver her at 37 completed weeks. In our time, we used to do at 40 weeks, expected date of delivery. But the new notion is that you have to deliver at 37 completed weeks, because there's no point of waiting, because if you wait longer, there might be complications more. But what about the severe preeclampsia or preeclampsia with features of severe disease? What we are going to do? And it is the consensus that all the nice guideline. I don't want to say so many guidelines. I just wanted to say the whole world sat together and they decided what to do with the severe preeclampsia or preeclampsia with the severe disease. Should we wait up to 37 weeks? Actually, they said the cutoff point is 34 weeks of gestation. If 34 weeks gestation is there, probably that is the right time to deliver. But the problem, the patient, if there are preterm, less than 34 weeks, maybe 30 weeks, maybe 32 weeks, have severe preeclampsia, what to do? Should we wait? Well, that actually is the dilemma. That is the most challenging part to treat the preeclampsia. Mode of delivery? Well, actually, this is, I already mentioned, you see, the mode of time of delivery, 37 completed weeks for the mild preeclampsia, 34 weeks of the severe preeclampsia, if possible. And mode of delivery, preeclampsia is not the indication of C-section. You can go for normal delivery. That will be very much appreciated. And if there's a reason, if there's an indication, you can go for the C-section. Place of delivery, it is very important because the preeclampsia may result into pulmonary edema, stroke, death, retinal detachment, heart failure, and HELLP syndrome, and renal failure, abruption placenta, preterm birth, PPH, lot of complications. So this type of patient need a very tertiary center where all the backup service for both the mother and the fetus, neonatal backup service should be there, and high dependency unit or ICU that should be present to combat the maternal complication, to combat the fetal complication. So place of delivery is also important. 3 important things. Time of delivery, because this is the most important time. We can end up the preeclampsia by delivering in right time. And mode of delivery, yes, that is actually not preeclampsia is responsible for cesarean section. It is individualized, it should be individualized. Place of delivery should be tertiary center. Postpartum care is very simple, not that difficult, but there's no consensus that we have to do like this way, that way. But the important thing, as she's a preeclampsia, severe preeclampsia, we have to monitor vital signs every 2 hours, where the patient remains in the magnesium sulfate, and we have to repeat the laboratory test. That is very important. Platelet count, creatinine, liver transform, which were very much derailed. What happened to them? We have to measure them, and we have to measure them daily until 2 consecutives are normal. When 2 consecutive results are normal or it is decreasing, then probably patient is safe. And of course, meanwhile, you have to look at her vital signs, her breast, her abdomen, her PB bleeding, and how she is, and of course, how the baby is, whether breastfeeding, how the mom and the baby, we have to look after. So by this I would like to finish, but one thing I want to say. Now the question, Madam, you said if mild preeclampsia, we will deliver her 37 weeks, completed weeks. And you said if severe preeclampsia, you have to deliver 34 weeks. What will happen if somebody comes at 30 weeks? Well, definitely we have to admit her in the hospital and we have to give her conservative treatment. I already mentioned there principle of treatments. Rest, antihypertensive, steroid, magnesium sulfate, and checking regularly, monitoring her blood pressure, her vital signs, baby's antenatal fetal surveillance, and of course some biochemistry. And if those are fine, we can continue up to 34 weeks, and no point of going after 34 weeks once there is already organ damage. But if it is not possible, if the fetal condition deteriorates, if the maternal condition deteriorates, definitely you have to terminate the delivery, terminate the pregnancy, because mother's life, fetal life is more important than, to continue the pregnancy. So you have to balance the risk and benefits, then you have to decide. But simple, in simply black and white is that if 37 completed, we can deliver her. If 34 weeks, no need to go beyond that. And before that, do the conservative management as much as possible. And then preeclampsia can be prevented, progression of preeclampsia can be reduced, and we can save many maternal deaths from eclampsia. Thank you very much.